What I'm going to talk today is to share with you the innovative models, innovative clinical models in HIV prevention and care. And okay. So I think that we have seen these cascade figures several times during the conference, and we all realize that there are large opportunity gaps either to reach key populations, to bring them in for HIV testing, and then to link HIV positive people and start ERT immediately and retain them in ERT care. And also to link HIV negative people in HIV prevention program. And I think that there is certain needs for innovative ways to close that gaps. And I'm going to share with you the two innovative models, which I feel, it may not be true, but I feel it is the most feasible and most scalable way here. The first model is the community-led HIV service delivery model. And I'm talking here beyond the conventional roles of community staff to provide education, to distribute condoms, but actually for them to deliver the services to target populations. And the second model will be the online platform, which I think we have heard several presenters during their conferences here showing that this is a very high potential model to enhance this cascade. And I'm going to use pilot programs for MSM and transgender women in Thailand as an example to show how community-led HIV delivery and online platform can be integrated into this recruit, test, treatment and prevention, and retain cascade. And you can see here the yellow highlighted text which show where the community-led service delivery and online platform can be key facilitators in each step of this cascade. And for Thailand, we have men who have sex with men or MSM population contribute to more than half of new HIV cases each year. And still, HIV testing coverage among Thai MSM is less than 30%, and just over half of them came back for repeat HIV testing within a year. And referring to these ambitious UNAIDS 90-90-90 targets, altogether with the 3 90s, you will be able to get 72% of all PLHIV having suppressed viral load. But Thailand in 2014, we have reached 83, 74, and 75, which seems beautiful. But altogether, these three numbers will give you with only 42% of total PLHIV in the country who achieved suppressed viral load. So the data in the previous slide, data in this slide, altogether confirms that we still have to put much more efforts if we aim at ending AIDS in the next 15 years. So let's start with the community-led HIV service delivery. And we are fortunate to work with support from USAID PEPFAR with 7 drop-in centers, 7 community-based organizations in 4 big cities in Thailand, which is Bangkok, Chiang Mai, Pattaya, and Hat Yai. And these are CBOs working with MSM, transgender women, male sex workers, transgender sex workers. And the aim of this work is to strengthen capacity of community staff to be able to deliver the service all through the cascade. So that starts from recruit people into the program, provide testing, provide treatment, provide prevention, and then retain both HIV positive and HIV negative clients at their drop-in centers. And over the past 2 years, we have been worked successfully with these community staff who are non-healthcare professionals. They're non-healthcare professionals, but they have their capacity strengthened to either didactic trainings, hands-on training, and they record their performance for service delivery performance in their performance logbook. And now they can perform blood collection through finger prick and use blood collected from the finger prick to do HIV testing, to do syphilis testing, to do CD4 count measurement. And this is through the availability of the rapid test kit and the point-of-care CD4 count machine. They can also collect samples from anus, neovagina, and oropharynx for STI screening. And they can even do TB screening through tuberculin skin test and provide INH prophylaxis therapy for people living with HIV who they care for at their drop-in centers. And the ongoing coaching, quality assessment, quality improvement are provided not only by the team from the Thai Red Cross, but also now by healthcare professionals at local public health facilities who now consider drop-in centers as one of the official HIV service delivery sites in certain provinces. So this is now kind of gradually integrated into the regular system. And beyond providing HIV and STI testing, these community staff can now provide PrEP services to their HIV negative clients as well. And this is beyond the role that we can see that community staff, they are good at generating demand for PrEP. Not anymore. They can even provide PrEP to their clients at their drop-in centers. And we have now expanded these community-led PrEP services in order to reach a larger number of key populations. And this is through the availability of the Princess PrEP program, which I will be explaining later on. And this slide is just to show to you some figures to support the feasibility of the community-led HIV service models. And over a one-year period, we were able to reach and enroll approximately 1,800 MSM and transgender women into the program. 1/3 of them are transgender women, another 2/3 are MSM. And we have seen a HIV positive rate of around 17%. It's 10% among transgender women and 19% among MSM. And overall, 99% of those who diagnosed positive at these drop-in centers agree to have ART initiation regardless of CD4 count. And 81% successfully started ART. Through these drop-in centers. And you can see in the yellow fonts there that the median time between HIV diagnosis and ART initiation is only 15 days, which is a very nice figure compared to the data at the national level on how soon you can get people from diagnosis into ART initiation. And it's not only the successful early ART linkage. This model has also demonstrated that earlier HIV diagnosis is also feasible through community-based model. You can see here, when we compare the median CD4 count at ART initiation in the country, in Thailand, it's just above 100. But here, you diagnose people, the median CD4 count at their first diagnosis is 373. And you can see that almost 1/3 of them had CD4 count above 500, which is very nice. And we also demonstrated that the populations that we reach through this community-led model is different from the populations that you will need through conventional HIV testing clinics. You can see on the bottom of the slides that these are people who had lower education, who had lower income, but they are practicing or having very high risks. STI, any STI, either that being syphilis, gonorrhea, and chlamydia, was found in 1/3 of this population. And 80% reported condomless sex, and almost 10% reported the use of amphetamine-type stimulants within the past 6 months. And after a few months of running the community-led test and treat program. These drop-in centers has started to offer PrEP for their HIV negative clients, and this started in October last year. And among 302 HIV negative clients who were offered PrEP, we can see that PrEP acceptance rate is around 54%. And these PrEP are provided on the same day that these clients coming in for HIV testing, HIV negative status confirmed, and then you get the PrEP medication. And these services are provided by trained community staff at these drop-in centers. And as I mentioned before, now we are expanding this community-led PrEP service through the availability of this Princess PrEP program. And we, at the Thai Red Cross, we have this famous Thai Red Cross PMTCT program, which is a public donation fund initiated by Her Royal Highness Princess Somsawari. And just recently, this year, this fund, this public donation fund, has been transformed from being PMTCT fund into being HIV prevention fund. So now we can use this fund to provide HIV prevention to other key populations as well. And our princess has been so kind that she provided this blessing quote to encourage and to support our colleagues who are providing community-led PrEP services. And the Princess PrEP program was launched early this year. And the aim is to provide PrEP to 1,000 MSM and TG per year for the next 3 years, while the country is working towards integrating PrEP under the national healthcare schemes. And during the first 3 months of the program, almost 300 people has been started on PrEP. And now I would like to switch to the online platform model. The online platform model, we, all of us sitting here, I think we all realize that lots of young MSM and TG, they are connecting online to engage in offline risk. And we have heard from many researchers in this conference that we can reach these high-risk people online. But the real challenge, everyone have been challenged on how we actually can convert that online reach into the offline uptake of HIV testing or the offline uptake of other HIV services. And I'm just going to show you a few examples of how we can successfully reach these people online. Adam's Love is one of the very successful online platform, which reach millions of MSM over a 4-year period, and has initiated discussion around sexual health through various online communication platforms between the Adam's Love staff and people who were reached online. And more than 10,000 referrals to HIV testing, STI testing have been made over these years. APACC has also been exploring exciting online reaching model for MSM. And the latest online campaign is the use of Gay OK Bangkok, the series. So it's the series of 5 movies launched weekly. And within just less than 2 months, more than 1 million viewers were reached. And this has dramatically increased the number of people who visited APACC's website, number of pages viewed, number of online communications with APACC staff about HIV and STI and PrEP. And these are the series that portray real life gay story in big cities, gay men story in big cities. And it also includes stories about discordant relationships among gay men, the use of PrEP, etc. So it really generate demand, generate interest around HIV, STI, and PrEP among MSM in big cities. And as mentioned before, we have shown, we know that we can reach these people very successfully. We have heard that in Hong Kong, you have this chrysanthemum tea campaign, which means it's an anal health campaign, which has been successful as well. But the real challenge is how to convert this online reaching success into successful offline service uptake. And therefore, Adam's Love team has started the demonstration project early this year, and we call this project the Online to Offline campaign, or O2O campaign. And in this campaign, HIV and PrEP message were launched and reached high-risk MSM and TG online. And those who are interested will be provided with online counseling around HIV and PrEP. And those who would like to further access HIV testing or PrEP service will be able to do online booking, in which you will get this ticket with the QR code. And then you can use this QR code, the ticket on and the QR code, to proceed directly to the clinics and then get fast-track HIV testing and PrEP services. Okay? And during this 3-month period, 425 MSM and TG booked online. And we can see that 325 or 76% actually presented to the clinic. So it's very high. We wouldn't suppose that people who just do online booking will actually present it to the clinic, but we have seen that 76% actually present to the clinic. Half of them decided to only have HIV testing, another half decided to start PrEP. So this is a model that I think would not be too challenging to scale up, and it can be used either for HIV testing, can be used for PrEP. And furthermore, the online platform can also use to further support the HIV testing step. And here is the work with MFAR GMT initiative grant support to demonstrate the online supervised HIV self-testing model. And in this model, everything happens online. From recruit people, recruit people, do online pre-test counseling, and then go through the supervised HIV self-testing together. And this is through the use of the electronic health record system embedded in as part of the Adam's Love platform, which allow real-time face-to-face chatting, video chatting feature, so that counselors and clients can meet online and can go through the HIV self-testing process together with clients' own privacy, but with real-time supervised supervision provided by trained online counselor. So we are still learning on who will be the subset of MSM and TG who will be interested in this all online model. And we are not saying that this will replace the offline service delivery, but it will supplement the service that we have right now and to reach those who are harder to reach populations. And we cannot talk about HIV self-testing without mentioning oral fluid testing, because with the online supervised self-testing model, we're using the blood-based self-testing. But here, I have to say that being in this conference, learning from other researchers in this region, Thailand is still much behind Hong Kong, China, Cambodia in terms of self-testing, and it will be only later this year that we will start this pilot study on oral fluid testing. And this will be oral fluid testing in community-based venue and home-based venue. And we are hoping that rich information will be generated through this study and will be used to support registration of oral fluid test kit in the country, and also to support the changes in the policies, in the regulations, much more in the country to allow self-testing to be feasible in Thailand. And lastly, I'm going to talk about the use of the online platform to actually provide real-time monitoring of the performances throughout the cascade, from reach, recruit, test, treat, and retain people in the cascade. And in Thailand, we call this eCasket. And this is the activities led by FHI 360 Linkages program. And it is based on the ComCare mobile application, in which you can track the performance and through each step of the cascade. And this is just the figure to explain how the eCasket works. It starts on the top with outreach workers who interviews the clients, enters information into their mobile phone. And then the mobile phone will calculate whether or not that client needs referral to HIV testing. And if that client needs a referral to HIV testing, then the digital referral happens, which means that the code number of that client will then appear on another mobile phone used by the staff at the HIV testing site. And once the client presents to the clinic, then the staff press on that code number, and the system will automatically know that you now have a success jump from outreach to HIV testing. But if the clients did not present to the clinic, then the system also generates automatic message to the client's mobile phone and to the outreach worker's mobile phone, reminding that the referral has not been successful. And then this digital referring happens again between HIV testing sites and ART sites. Once you have HIV positive clients diagnosed in the drop-in centers, then this digital referral and data record on the performance of the successful of referral will also appear in the system. And with the use of the eCasket, Linkages program also are now piloting the model called the Enhanced Peer Mobilizer models to try to reach more key populations through social networks. And there will be three group of people in this model. The first group is the community-based supporter, who are community staff or with salary, who will then recruit peer mobilizer. Peer mobilizer are actually clients who are coming for HIV testing at your drop-in centers, who show some potential to have many friends and be able to convince friends to come for HIV testing through their social networks. And once their friends who are clients coming to HIV testing at that drop-in centers, that client can be approached by community-based supporter again to be additional peer mobilizer. So it's like a never-ending network that can happen. And this may seem very similar to the conventional outreach model, but actually we are only paying the salary of the community-based supporter, not the peer mobilizer and not the client. So we are not paying for people to come for HIV testing. And with the use of eCasket system, we can track the performance of each peer mobilizer. So in this case, you will see that there will be those peer mobilizers who are super recruiters. They have so many friends, and their friends agree to come for HIV testing. And then you find many friends represented by the red dots who tested HIV positive, so it's high HIV positive yield. And these are recruiters, the types of peer mobilizer that we would like to keep in our program so that they can continue to bring more friends into the system. But there are also those peer mobilizer who actually do not have many friends or do not have friends who came for HIV testing and then tested positive. And these are peer mobilizer who we can just stop their involvement in the program. And With the use of eCasket that you can see on the previous slide, we can then prioritize who are effective peer mobilizer. And this is an example of the details that we can see from the eCasket system. This is one peer mobilizer who can recruit 29 friends into HIV testing. The testing acceptance rate is 96%, and the testing yield, the positive testing yield is 14.3%. So this is type of effective peer mobilizer. And if you look at the graph on the right side, during the less than 1 year period of this eCasket and enhanced peer mobilizer model, what we can demonstrate is that the HIV testing uptake through this peer mobilizer model is very high at 94%. And this is a dramatic increase, dramatic change from only 7% testing uptake rate through the conventional outreach program under the last round of the Global Fund in Thailand. So it's 7% to now 94%, and you pay less. And also the HIV positive yield is 10%. And in addition, we also see that the ART initiation rate was very high in this peer mobilizer program. It's 83%. So in conclusions, I think that we all know that it is feasible and it is needed to establish and to further enhance the community-led service delivery models on the online platform if we are aiming to end the AIDS epidemic within less than 2 decades from now. And we have been so impressed working with CBOs and see how much enthusiasm they have, and also to see how they feel proud to have their capacities strengthened to be able to now deliver service to their own community. And it is different from just a few years ago that community staff are seen as just recruiter for research projects. No, but now they are being researchers themselves and being service providers themselves. But we also see that challenges are ahead on how we can effectively and timely address structural barriers to institutionalize and to finance community-led programs and online platform programs to make sure that it will be a sustainable programs in the country. And Thailand will use the next 2 to 3 years during the Global Fund transition period to make sure that we institutionalize, we find a way to finance these models. And the next steps is also to enhance the model for other key populations or to explore model in other key populations. For transgender women, we still have to, what we are doing is mainly based on MSM in particular, but we have we can see high potential that this can be enhanced for transgender women population as well. And also this can be explored with other key populations such as youths, such as people who inject drugs. We have heard from the previous speaker about the use of innovative drugs for people who inject drugs, but we can also have innovative models for people who inject drugs as well. And I believe that more innovative and exciting models will continue to arise. This is just few examples. It will continue to arise where commitment and enthusiasm are shared among stakeholders in each country. And I would like to end by acknowledging all partners, colleagues that have been working with us within the past decades in the country. And I hope that what I have shared with you today will be of some use for you in your own settings, in your own country, with your own key populations. Thank you very much.